So first question we got is a rather broad question, which I think is deceptively simple. Is syringomyelia considered a disease? Somebody want to take that?
You can take that.
Well, it's a condition. It usually arises from an underlying condition, but sometimes it's considered idiopathic. That means we don't know what its cause is. So it would be, yeah, I think it's a disease, sure.
I think when it's significant and causing symptoms, it would not be controversial that it's a disease.
Right.
There's a medical diagnostic code for it. I think everyone agrees with that. I think the controversy is an asymptomatic patient with a small syrinx. When does that become a disease? And that's almost unanswerable, I think.
It's, yeah, there's a controversy. It's like with Chiari. Is Chiari when the MRI shows that the tonsils are 5 millimeters below the foramen magnum, or is it when it causes symptoms? When does it become a disease? So it's philosophy.
Probably a good rule of thumb is whether that, the syrinx size, girth, or length is changing in some way. Then you can imply that there's a pathological process probably driving the development of it that in the appropriate circumstances you might want to do something about with a surgical intervention.
Next question is, how does lumbar pressure correlate with cranial pressure? And I think the question really is about the value of diagnostic lumbar punctures for measuring ICP. So, Dr. Kula, you want to take that on?
Well, in the absence of any apparent obstruction between the upper reaches and the posterior fossa and the cerebral hemispheres and the distal part of the cord, in the appropriate position, that's where the patient is in a lateral decubitus position with the knees slightly flexed but not impacting the abdomen, and is relaxed and not hyperventilating. We would assume that the pressures are relatively similar. There's ways to kind of have a look at that. We can do some simplistic testing. For instance, producing pressure on the jugulars here would increase venous pressure in the head. You can see the spinal fluid pressure in the back go up. You would imply then that pressure is being communicated across the posterior fossa. There can be some circumstances where there might be perhaps some a difference in that if there was flow obstruction, but I don't know. I would ask you about that, whether you think that how often that may occur.
Well, I think if you think someone has pseudotumor cerebri, I think that there's good correlation because the numbers would be very high in the lumbar puncture. The pressure between the intracranial and the spinal fluids about the same, because I don't want to use an analogy like Paulo, he sort of wore him out, but anyways, it's a fait accompli. It's a finished act. When there was a difference in pressure, the tonsils probably moved down, but they've come to a level where the pressures are equal. So even with Chiari, there's usually a little bit of fluid that will equilibrate pressure. That being said, there are pressure differentials, presumably with coughing, with straining, and things like that. Acute events, things that occur over a short amount of time, and there's not enough time to equilibrate the pressure. So,
I think if you're measuring the lumbar spinal fluid, it's appropriate to have in your mind that it's not exactly a perfect test because you're assuming the needle is placed properly, that one of the spinal roots doesn't occlude the opening of the needle, that you're observed it for a reasonable enough time. I've sat sometimes for as much as a half an hour observing the fluid. You can oftentimes see nice cardiac and respiratory variations in the fluid, which would be appropriate, but some children that I've done will hyperventilate, and that can drop the intracranial pressure maybe 50, 60 millimeters. And if you wait and the child is calmed down and they're not afraid of any sudden pain in the back, pressure will come back up to normal. So hyperventilation, which we use to control intracranial pressure, can have a significant influence. And if you just get in there and get out, you may, get a misreading.
Yeah, there should be a good reason for doing everything you do. If you think you have hydrocephalus but you're not absolutely sure, you might want to measure pressure in the head. If you think that somebody has pseudotumor, you might want to do a lumbar puncture. If patients with primary spinal syringomyelia that have a lot of scarring and a complete block, they will not have pressure variation. There'll be a complete block, a disconnection of the spinal fluid space above and below the block. So, really a physician has to think long and hard about whether the benefit of doing the test is equal to the risk of doing it.
Right. I think we would all, sorry, go ahead.
No, I was just going to say, I think there's a little arbitrariness in what the normal result is, which I think can confuse patients. It confused me. I mean, when I got involved with Dr. Millerad, originally he would say, well, neurosurgeons determined 100 years ago, and the pressure was 150 millimeters. And I said, well, neurologists were always told, normal pressure is up to 180, maybe to 200. And if you look at the pseudotumor group, they really don't think, you have to, before they really get serious about optic nerve fenestration and the issue of papilledema and visual loss, they really don't get too aggressive unless the pressure is above 250. So, there is this, it's not an absolute fine line. Anxiety, tension in the abdomen will increase pressure. And there are normal variations in intracranial pressure that can occur following head injury and that are, just like your blood pressure, can be variable. So it's, there's not just one number, is the point.
I think we all agree that under ideal circumstances, lumbar punctures can be useful for measuring ACP. The trouble is arriving at something that's an ideal circumstance, especially in a pediatric practice. And I've got to the point where if ICP is important in directing a surgical treatment, I don't trust lumbar puncture numbers anymore, because we've seen it just so many times where somebody has a supposedly elevated pressure by lumbar puncture, and with invasive ICP monitoring, they have completely normal pressures.
Yeah, I mean, since Dr. Rickate's been with us over there, I mean, we don't put shunts in anybody without intracranial monitoring with a pulse.
So I think that's the key. If we're actually making an important lifelong surgical type decision for somebody, we really need the best possible information. And at least for me, lumbar punctures are not good enough.
Yeah, no, I actually would agree with that. In training, Ricate we'd frequently do ICP monitoring and lumbar punctures, and you actually you sort of assume it'd be more similar than not, but oftentimes there is often a discorrelation between the two, and you'd see much higher pressures with actual ICP monitoring. It seemed to be a little bit more specific for these kinds of things, and especially when you're considering doing a surgical intervention for somebody that's it's a pretty serious thing, and so I think it makes more sense to be as specific as you can.
So just as a side note, thank you once again to the audience for your questions. We've had outstanding response. We have about 30 or 40 questions. I know we're not going to get to all of them this session, but we are going to get to them. We're just going to keep bringing them back till we've answered all of them. The next question is, can a concussion start symptoms of Chiari?
Well, since Roger's group did the study, I'll say yes. I believe it was about 15% of patients with Chiari had a concussion before, some sort of head trauma.
It was kind of just a retrospective questionnaire, and about 25% had a prior head injury with, where they tagged the progression of headache symptoms to an event, whether it was a minor head injury or a car accident.
It was a surgical population. 20+% of the patient underwent surgery.
They can't hear.
The mystery of Chiari is how a congenital abnormality can present later in life. Supposedly, you've had the problem your whole life. So what tips you over the what tips the balance? Why does something that probably looks the same the next day, why does that become symptomatic? If you had an MRI before you had symptoms, MRI after the symptoms, what tips the balance? And as Dr. Kula said, sometimes it seems like head injury will do it.
Another common precipitating factor, people will come in oftentimes and have had a motor vehicle accident or even childbirth seems to be somehow associated sometimes with aggravating symptoms.
Yeah, that number, there was also a little question in there about pregnancy, labor, and delivery. When you actually sort it out by the numbers, 16% of the women attached a worsening in their symptoms. I'm not sure among what other things to childbirth and labor.
Yeah,
and delivery.
traumatic birth is supposedly related to Chiari. Bernard Williams mentioned that as one of the causes. If you have a Chiari, that traumatic birth can cause a Chiari, a traumatic birth can cause arachnoiditis that makes the Chiari worse.
Actually, we're kind of looking at this. I'll talk about it on Saturday. I'm going to give a little talk about pregnancy and labor and delivery and Chiari. But what's really interesting to me is how, when you look at what we've been doing is looking back at the history of women that have had Chiari and may have had surgery or whatever at their pregnancy, labor, and delivery history. And by and large, with the middle-aged female population, we have 30, 40 patients that have had, childbirth with, epidural, sometimes spinal anesthesia, and really have tolerated it all very well and had very little in the way of complications. Once we know there's a Chiari and the patient gets pregnant, everybody gets concerned about how do we, should we do spinal, should we, try an epidural, or how do we deliver, should they push, should they not push? But when we didn't know they had a Chiari, actually so many of the women, I would say almost 90 plus, do marvelously. They don't attach any problem to it. So,
Just the last comment on trauma and his presentation with Chiari. I think we have to be really careful too, because obviously you get concussions after trauma and people present with post-concussive syndrome and headaches, and then they have a Chiari on MRI, as a large number of people will have. So we have to be careful and tease out, is this a traumatic presentation of Chiari, or is this post-concussive syndrome that's going to get better in a month or two? So you got to be careful with that and not operate on somebody that has a benign natural history. Dr. Heiss, does the duration of Chiari and/or syringomyelia prior to treatment have any relationship to pain reduction and functional improvement?
I don't think we have the data, but in general, anyone who has progressive syringomyelia should be treated, because really there's no going back. Once you lose it, you can't get it back. That being said, there are people who have had, they've had scans from the 1990s and they know they have syringomyelia. They've really not had any neurologic decline, and their syrinxes aren't distended. That's important. So I think, if you look at a Netter diagram, it'll say syringomyelia is a progressive disease. It must be treated, otherwise you'll end up in a wheelchair. I don't think the majority of people will have that end result. So, but I think you have to go to someone with some experience to know who to follow, and so I guess that's the benefit of going to somebody with some experience in the field.
There's a question about what pain medicine is proper to give a child or teenager. Dr. Kula, I don't know if you want to take that on, or if you'd rather defer to the pain talk.
With what?
It doesn't say, I presume, Chiari.
well, you first have to analyze what the headache is and how many kinds of headache patients have. So if you go into the history, 20 to 30% of the female population has migraine. So 20 to 30% of the Chiari population is probably going to have migraine in the female group. It's a little less common in males, but you want to be sure, because you can treat migraine in any number of ways. There are a lot of effective treatments for migraine. So if the headache sounds like migraine, you ought to treat it like migraine. If it sounds like a posterior fossa headache, then the approaches to that may be somewhat different. Usually triptans and beta blockers and all the other things that are used for migraine don't really help the Chiari headache, and that's the experience many Chiari patients have in the headache clinics. There are headache clinics all over the United States run by neurologists who are anxious to treat migraine, and you have migraine until proven otherwise. I have a very low threshold to try to treat someone with Diamox, even in the children's population. It's fairly well tolerated, but it sometimes can be a proof of concept if patients respond to Diamox, which lowers intracranial pressure upwards of maybe some cases 20 to 25% CSF, lowers CSF production, can have a significant impact on posterior fossa headache. And maybe I would say maybe 30 or 40% of patients will improve with it. And whether it's tolerable, whether they have allergy to it, there are a number of issues, but it's worth trying. I find really too many patients haven't had a trial, even a trial of it. But
Who is the best person to read an MRI? No easy answer for that. Huh?
Well, I must say that for almost all the conditions we operate on, tumors, Chiari malformation, benign tumors, the decision to operate is not on the basis of a scan. The decision to operate is always on the basis of the symptom presentation. Does somebody have a neurologic deficit? Is it getting worse? That's the prime thing. So I would say that whoever's looking at the scan should be informed what the alternatives are, and they should have already made up their mind what they were going to do.
Yeah,
I'll just tell you two interesting anecdotes. Well, you might say maybe a Chiari-affected patient might be a good person to read it. We had a patient that was admitted to North Shore by one of the neurologists, and one of the 60 neurologists on the North Shore of Long Island, and the patient was being treated for intractable migraine. And we had a patient in the next bed, and she said, "Oh, I have my imaging here." So she said, "Mind if I take a look at it?" So she said, "Oh, well, you have a 15 millimeter Chiari malformation, and maybe that's what's causing it." And sure enough, that was a problem that had been completely missed. And then I talked to a neuroradiologist at one point, and I said, "Here's a 10 millimeter Chiari." I said, "You didn't report it." He said, "Why should I report it and give some neurosurgeon an excuse to whack the back of their head off?" So I said, "Well, that's not your job to make those decisions. You should read the imaging, And so some radiologists, labor on the side of not trying to identify that, unless it's really, they have drunk the Kool-Aid, saying, well, the Chiari is really asymptomatic, it's an incidental finding, or they'll report it in the main part of the reading and will not report it in the impression. I mean, it's frequently patients will get their reports. They said, I have chronic headache. My neurologist isn't treating me for migraine, but I got my MRI report, and here it says Chiari malformation, and my neurologist never told me I had that. And it's because it really wasn't in the conclusion, and they maybe didn't pay that much attention to it, or they thought it was an incidental finding.
There has to be a balance, though, because we can get into trouble going the other way as well, and we see that all the time, where the radiologist reads it as normal because it is normal, and they've seen a surgeon who said, no, this isn't normal, and very few people would read that scan and see an abnormality, except for the surgeon who operated.
Well, that happens too.
And so that has to be, I have to say, a significant problem as well. And so to some extent, I think a well-educated, good radiologist probably is a good arbitrator in most cases. How do you know when your decompression fails? What are the symptoms of a failure?
Well, if they have syringomyelia, if the syrinx doesn't get significantly smaller over a period of 3 months to a year, then, and if the symptoms get worse in terms of, say, you have some weakness or loss of sensation in an arm, upper extremity, if that's getting worse and the syrinx is persisting or larger, then you know it's failed. There are other radiographic things that we look at on the MRI. The flow pathway around the tonsils hasn't enlarged. So those are the main things. Now with Chiari, no syrinx. It's very difficult. The neurosurgeon tries to create the CSF pathway and decompress the foramen magnum. That's pretty much what we can do. I would say that I'd be hard-pressed to reoperate if I had a good morphology or good pathway of CSF across the foramen magnum. So, but that being said, you have to check for instability of the spine after surgery. Other things can cause the surgery to fail.
Next question is, what point does the change for more males having Chiari as the child grows and into more females as an adult? What's the explanation for this? I think in most series that's not the case. In our series, we looked at thousands of people, and it's always more females than males in every age group. I don't know if you want to address that, because I know at Duke it seems to be different. Yeah.
No, I don't think it is. In France, it's the children in the pediatric group, it's males equal females, but it's not as, in adults, it's not as pronounced in France. It's almost a U.S. phenomena that there are more women affected.
And if you just study the population and posterior fossa anatomy, girls and women at every age group just have a slightly lower average tonsil position than males, and it's probably related to that. I think that's the explanation, in my biased opinion. Would you suggest that we see only experts in Chiari? Probably, yeah.
Makes sense.
Yeah, it makes sense. Let's
You know,
see.
There's one thing I wanted to actually add to one of the previous questions. You know, when patients have symptomatology and they go through surgery and they get better for a period of time, and then they subsequently have symptoms that return, you always have to worry. One thing that I think some of the surgeons have talked about is scar tissue formation, and you know, looking very carefully at the CSF flow after somebody's had a surgery can be helpful. I know that many people use that. And sometimes just an MRI versus a CSF flow study can help you actually see if there's enough flow in the posterior fossa. So that's just one thing to think about.
Yeah, because of Hal Rickate's interest in venous obstruction, I mean, we've been doing a good deal more venous MRVs, looking for perhaps postoperative venous occlusion or thrombosis, you know, in a patient that may have had a complicated post-op course with inflammation or infection. So I think you just have to say, did I miss something? Is there some other process that's causing a less than, you know, good outcome? Sometimes you just don't have an answer for it, unfortunately.
And in the patients that never get better, you always have to wonder if it was really from something else to begin with. So.
Right. So we have two different questions here, which I think I'll combine. Are chiropractors helpful, and what about massage therapy? Is that helpful?
Well, I try to steer people away from chiropractors, especially for neck manipulation. It depends on what the chiropractor is doing, kind of. For low back pain, sometimes minor manipulation for some patients is helpful. But in the neck, I think I was in my residency, which is now a long, long time ago. One of my co-residents reported, I think, the first case of vertebral dissection following, manipulation, chiropractic manipulation of the neck. The other thing to mention about chiropractors, there's a group of people out there that call themselves Atlas orthogonists. And they propose to move the atlas and with thumping procedures that readjust the cranial cervical junction. I have no idea really what they're doing, but there's a couple of thriving practitioners around the New York upstate area. They're also involved in very intensive video tomographic assessment of the cranial cervical junction and all ranges of motion. And the question is, you know, some of the radiologists that are reading this out have very high abnormality issues, and they're mainly involved in litigation cases where patients go into court and the radiologist says there's instability here. And, you know, we look at it, and not just me, but the neurosurgeons really, and they just, there's no odontoid instability, but they say lateral, rotational, and it's really, I don't know if you've come across patients that have been looked at, but they come in with it's a lot of radiation, actually, because they do video, high resolution, rapid sequence video of the patient doing all sorts of neck motions.
Next question is from somebody who's noticed that many people have had multiple unsuccessful operations. After an initial successful decompression, have had multiple further surgeries. The additional surgeries are for conditions that they didn't have previously. Is it possible that resolving one condition opens up those to new problems or somehow leads to them?
I'm not sure what other problems.
It wasn't stated.
Well, I think if you have surgery, it goes well, you don't have any scarring, then, and the person, the syrinx goes away, that's great. But in some cases, there will be what's called arachnoiditis, especially when the arachnoid's open and if some blood gets in there. And that can cause scarring, and that can make a worse condition, actually, than what you started with. So what you want to do is you want to go to a surgeon with a low complication rate, and meningitis can occur after surgery. It doesn't happen very often. That's a complication that can lead to scarring. That can lead to hydrocephalus, which is another condition. So if everything goes well, you don't have secondary conditions. But it is possible with complications of surgery to have secondary conditions. As Paulo said, if your decompression is perhaps too wide, you might, if you were just barely stable, you could have some spinal instability. So if you, surgery can make you worse, but hopefully you want a low rate of complication.
That was me, and I didn't think to be more specific, but things like people have decompression, and then maybe that later on they have tenant cord, and then later on they have something else, that are all conditions that relate to Chiari Syringomyelia, but they weren't there originally. I didn't mean something like infection.
Well, I think the question sometimes is, were they there originally and just not recognized and now become observable components to it? That's one issue. I think, what we've endeavored over the last number of years is try to find out what are the components of an adequate or good surgical treatment, what are the appropriate materials. I mean, I'm not a surgeon, I really should, I guess, I keep my mouth shut, but, I mean, the question is, Paul is laughing, but I think patients that we've seen, the most difficult patients are patients that have had 3 or 4 decompressions. I think patients that have recurrent surgery, just, it's just, you can't go to the well too many times, and there's post-op scarring. It's inevitable every time you cut, you make a scar, and so, it's good, I think, to advocate for having a good operation that hopefully is a successful operation, is aggressive enough, and does the job, and I think that happens for the most part.
Right, very important to get it right the first time, make sure you're doing the right operation for the right reasons.
Exactly.
Right.
Which is critical, I think, and then make sure you don't have any complications. There's at least 20 questions we didn't get to, and I apologize, but we will get to them. We will get to them this afternoon or tomorrow, I promise. At this point, we're already 15 minutes overdue for lunch, so we're going to take a break and meet back here at 1:30 for the next session.